Let us briefly review the anatomy of the thyroid. The thyroid gland is a butterfly-shaped, highly vascular organ located anterior to the trachea and below the cricoid cartilage and just above the suprasternal notch. Four parathyroid glands are located posterior to each pole of the thyroid. The recurrent laryngeal nerve traverses the lateral borders of the thyroid gland and must be identified during thyroid surgery to avoid injury and vocal cord paralysis. The main function of the thyroid is to produce the thyroid hormones thyroxine and triiodothyronine. The function of the thyroid hormones are for cell differentiation and organogenesis during fetal development and maintenance of the thermogenic and metabolic homeostasis. The thyroid is a classic example of the endocrine feedback mechanism. TRH released from the hypothalamus will stimulate the secretion of thyroid-stimulating hormone from the anterior pituitary gland. The TSH, which is the most useful physiologic marker of thyroid hormone action, will stimulate the thyroid gland to secrete thyroid hormone. When there is enough thyroid hormone secretion, it will send negative feedback both to the pituitary and hypothalamus until new steady state is attained. Hypothyroidism. Hypothyroidism is the most common disorder of thyroid function. It has multiple causes in which the thyroid fails to secrete an adequate amount of thyroid hormone. The causes of hypothyroidism can be generally divided into three: primary hypothyroidism, transient hypothyroidism, and secondary hypothyroidism. Most cases of hypothyroidism fall under the category of primary hypothyroidism, in which the thyroid fails to produce sufficient thyroid hormone. More infrequently, hypothyroidism is caused by decreased thyroidal stimulation by the TSH, which is termed as secondary or central hypothyroidism. There is a long list of causes of hypothyroidism. Shown to you are the different causes of primary, transient, and secondary hypothyroidism. Overall, it is still the primary hypothyroidism that is the most common cause. Primary hypothyroidism are commonly caused by autoimmune hypothyroidism, iatrogenic, and iodine deficiency. Iatrogenic causes include post-radioactive iodine treatment for hyperthyroidism, thyroidectomy or external radiation of the neck. Drugs containing high doses of iodine such as amiodarone and iodine contrast media can likewise cause hypothyroidism. Congenital abnormalities such as absent or ectopic thyroid gland and infiltrative disorder will all possibly cause primary hypothyroidism. Transient hypothyroidism can result from silent thyroiditis, subacute thyroiditis, withdrawal of supraphysiologic thyroxine treatment, or after iodine 131 treatment or subtotal thyroidectomy for Graves' disease. Secondary or central hypothyroidism can result from abnormality involving the upper center, the pituitary and hypothalamus. Tumors, trauma, infiltrative disorders, and surgery involving this area may result to secondary hypothyroidism. In primary hypothyroidism, low thyroid hormone secretion is due to a pathology in the thyroid gland itself. The low level of thyroid hormone will then send positive feedback to the pituitary and hypothalamus. Since the upper center are normal, it will respond to the stimulation, resulting to increased level of TSH. However, because the problem is the thyroid itself, it will not respond to the stimulation, giving us the biochemical picture of high TSH and low FT4 in primary hypothyroidism. In secondary hypothyroidism, the low thyroid hormone secretion is due to lack of hormonal stimulation from the pituitary or even the hypothalamus, giving us a biochemical picture of low thyroid hormone and a low TSH. Worldwide, iodine deficiency is the most common cause of hypothyroidism. In iodine-sufficient areas, autoimmune diseases like Hashimoto's and iatrogenic are the most common cause of primary hypothyroidism. Autoimmune hypothyroidism may be associated with a goiter, termed Hashimoto's or goitrous thyroiditis, or at the later stage atrophic thyroiditis. The mean annual incidence rate of autoimmune hypothyroidism is up to 4 per 1,000 women and 1 per 1,000 men. It is more common in certain populations, probably because of genetic factors and chronic exposure to high iodine diets such as the Japanese. The mean age at diagnosis is 60 years, and the prevalence of overt hypothyroidism increases with age. Subclinical hypothyroidism is found in 6 to 8% of women and 3% of men. The annual risk of developing clinical hypothyroidism is about 4% when subclinical hypothyroidism is associated with positive thyroid peroxidase antibodies. In Hashimoto's thyroiditis, there is a marked lymphocytic infiltration of the thyroid with germinal center formation, atrophy of the thyroid follicles accompanied by oxyphil metaplasia, absence of colloid, and mild to moderate fibrosis. While in atrophic thyroiditis, the fibrosis is much more extensive, lymphocyte infiltration is less pronounced, and the thyroid follicles are almost completely absent. Atrophic thyroiditis usually represents the end stage of Hashimoto's thyroiditis rather than a separate disorder. Susceptibility to autoimmune hypothyroidism is determined by a combination of genetic and environmental factors. HLA-DR polymorphisms are the best documented genetic risk factor for autoimmune hypothyroidism, especially HLA-DR3, DR4, and DR5. A weak association also exists between polymorphism in CTLA4 and autoimmune hypothyroidism. Both of these genetic associations are shared by other autoimmune diseases, which may explain the relationship between autoimmune hypothyroidism and other autoimmune diseases, especially type 1 diabetes, Addison's disease, pernicious anemia, and vitiligo. Environmental susceptibility factors are poorly defined at present. A high iodine or low selenium intake and decreased exposure to microorganisms in childhood increase the risk of autoimmune hypothyroidism. Smoking cessation transiently increases incidence, whereas alcohol intake seems protective. Antibodies to TPO and thyroglobulin are clinically useful markers of thyroid autoimmunity, but any pathogenic effect is restricted to a secondary role in amplifying an ongoing autoimmune response, and transplacental passage of thyroglobulin or TPO antibodies has no effect on the fetal thyroid. Up to 20% of patients with autoimmune hypothyroidism have antibodies against the TSH receptor. These TSH receptor blocking antibodies cause hypothyroidism and, especially in Asian patients, thyroid atrophy. Transplacental passage may induce transient neonatal hypothyroidism. Iatrogenic is another common cause of primary hypothyroidism. It can be a result of post-radioiodine treatment for Graves' disease, post-surgical hypothyroidism, or even iodine deficiency. The onset of the signs and symptoms of hypothyroidism is usually insidious, and the patient may become aware of symptoms only when euthyroidism is restored. The symptoms are usually non-specific and can range from simple tiredness to dyspnea. On physical examination, you might appreciate the presence of dry, coarse skin with cool peripheral extremities. Some may have diffuse alopecia, bradycardia, peripheral edema, or even serous cavity effusions. The clinical manifestation of hypothyroidism is nonspecific, and so there is a dissociation of the clinical and laboratory diagnosis in hypothyroidism. If we rely on symptoms alone, about 20% are true hypothyroid, but more than 50% are actually euthyroid. For this reason, guidelines recommend to look for conditions with compelling evidence to support case finding for hypothyroidism. Among these are the presence of autoimmune diseases like type 1 diabetes, pernicious anemia, or vitiligo. Those patients with first-degree relative with autoimmune thyroid diseases, prior history of thyroid surgery or dysfunction, and history of radiation to the thyroid gland also warrant examination. Abnormal thyroid examination, presence of psychiatric disorder, and use of amiodarone and lithium likewise support the case finding for hypothyroidism. The definitive diagnosis of hypothyroidism relies on biochemical quantification of the thyroid hormone, specifically the free or the unbound T4 levels. Subnormal levels of free T4 establishes the diagnosis of hypothyroidism. However, measurement of serum TSH level is also required to ascertain the type of hypothyroidism. Primary hypothyroidism is characterized by elevated TSH levels because of the lack of negative feedback to the pituitary gland. Secondary hypothyroidism is characterized by low or inappropriately normal TSH levels because of the pituitary pathology. A normal TSH level excludes primary but not secondary hypothyroidism. If the TSH is elevated, an unbound T4 level is needed to confirm the presence of clinical hypothyroidism. Circulating unbound T3 levels are normal in about 25% of patients and is not indicated for majority of the time. Once clinical or subclinical hypothyroidism is confirmed, the etiology is usually easily established by demonstrating the presence of TPO and thyroglobulin antibodies, which are present in 95% of patients with autoimmune hypothyroidism. Levothyroxine is the treatment of choice for the routine management of hypothyroidism. Levothyroxine preparations are manufactured in many different dosages and allow for the precise titration of an individual patient's requirements. There are three main goals of levothyroxine replacement therapy: to provide resolution of the patient's symptoms and hypothyroid signs, including biological and physiologic markers of hypothyroidism, to achieve normalization of serum TSH with improvement in the thyroid hormone concentrations, and to avoid overtreatment or iatrogenic thyrotoxicosis, especially in the elderly. If there is no residual thyroid function, the daily replacement dose of levothyroxine is usually at 1.6 microgram per kilogram body weight, ideally taken at least 30 minutes before breakfast. For those patients who develop hypothyroidism after the treatment of Graves' disease, there is often an underlying autonomous function necessitating a lower replacement doses. Adult patients under 60 years old without evidence of heart disease may be started on 50 to 100 microgram levothyroxine daily. For the elderly, especially patients with known coronary artery disease, starting dose of levothyroxine is at 12.5 microgram to 25 microgram per day. It is recommended that patients be evaluated at 6 to 8 week intervals until the serum TSH concentration is normalized. TSH normalization is the goal of levothyroxine therapy. Subclinical hypothyroidism refers to biochemical evidence of thyroid hormone deficiency in patients who have few or no apparent clinical features of hypothyroidism. There are no universally accepted recommendations for the management of subclinical hypothyroidism, but levothyroxine is recommended if the patient is a woman who wishes to conceive or is pregnant, or when the TSH level are above 10. Otherwise, when the TSH level are below 10, a trial of treatment may be considered when the patients have suggestive symptoms of hypothyroidism, positive TPO antibodies, or any evidence of heart disease. It is important to confirm that any elevation of TSH is sustained over a 3-month period before treatment is given. Treatment is administered by starting with a low dose of levothyroxine with the goal of normalizing the TSH. If levothyroxine is not given, thyroid function should be evaluated annually. Hypothyroidism in a pregnant woman is very important. It can affect fetal neural development and be associated with adverse gestational outcomes such as miscarriage and preterm delivery. Levothyroxine therapy should be targeted to maintain a serum TSH in the normal range but less than 2.5 for hypothyroid women. The levothyroxine doses may need to be increased by up to 45% during pregnancy. After delivery, the levothyroxine doses typically return to pre-pregnancy levels. Myxedema coma is a medical emergency and has a 20 to 40% mortality rate despite intensive treatment. Clinical manifestations include reduced level of consciousness, sometimes associated with seizures, as well as the other features of hypothyroidism. There may be a history of treated hypothyroidism with poor compliance, or the patient may be previously undiagnosed. Myxedema coma almost always occurs in the elderly and is usually precipitated by factors that impair respiration, such as drugs, pneumonia, congestive heart failure, myocardial infarction, gastrointestinal bleeding, or cerebrovascular accidents. Hypoventilation leading to hypoxia and hypercapnia plays a major role in the pathogenesis. Levothyroxine can initially be administered as a single IV bolus of 200 to 400 microgram. If IV preparation is not available, such as in our local setting, the same initial dose of levothyroxine can be given by nasogastric tube, although the absorption may be impaired in myxedema. Supportive therapy should be provided to correct any associated metabolic disturbances. External warming is indicated only if the temperature is less than 30 degrees centigrade, as it can result in cardiovascular collapse. Any precipitating factors should be treated, including the early use of broad-spectrum antibiotics pending the exclusion of infection. Ventilatory support with regular blood gas analysis is usually needed, especially during the first 48 hours.